Welcome and thank you for joining today's webinar on locally led action and outbreak response, hosted by the READY Initiative, which is funded by the Bureau of Humanitarian Assistance. During this webinar, we encourage you to ask questions using the Q&A function. We are happy to provide live interpretation into Spanish, French, and Arabic for today's webinar. If you're interested in listening to the session in one of these languages, please click the globe icon that says interpretation at the bottom of your Zoom screen and select your desired language. Access to today's recording will be available after the webinar on the READY website, ready-initiative.org. It is now my pleasure to turn it over to READY's Chief of Party, Laura Cardinal.
Good morning, everyone, and thank you for joining us today for our webinar. This webinar serves as the official launch of READY's recently published paper, Why the Delay? Perspectives of National and Local Actors on Progress Towards Locally Led Outbreak Readiness and Response. The paper, which was developed in collaboration with Anthropologica, consolidates local perspectives on actions needed to accelerate change for effective and meaningful locally led action in preparing for and responding to major disease outbreaks in humanitarian settings. You can access the paper and the corresponding two-page brief on the READY websites, the links of which will be shared in the chat now, and we will also be sending it out to all who joined the webinar after the call today. Today, you will hear a brief overview of the paper's key findings, and then we will have an expert panel discussion between global and national humanitarian and public health actors. The discussion today will be moderated by Dagan Ali, Executive Director of ADESO. Dagan is an internationally renowned humanitarian leader who has been at the forefront of shifting power for decades. She is a Rockefeller Foundation Global Fellow for Social Innovation, a contributor to the Overseas Development Institute Humanitarian Policy Group, and to the Global Food Security Journal. Dagan is also the co-founder of the first global civil society network for local and national humanitarian organizations, the Network for Empowered Aid Response, or the NEAR Network. We will start with a brief presentation from Anthropologica on the paper's key findings, presented by Dr. Juliet Bedford, the founder and director of Anthropologica. Juliet is recognized as a global leader in the application of anthropology in global health and has over 20 years' experience working through Africa, South, and Southeast Asia. She will be joined by Dr. Helen Smith, CEO of Anthropologica. Helen is a social scientist with 25 years of experience leading academic research, technical assistance, and teaching in international health. Following the presentation, Dagan will be facilitating a discussion with our excellent panelists, who I have the pleasure of introducing now. First, we have Dr. Iba Pasha. Iba is a technical officer at the Global Health Cluster, where she is supporting, developing, and implementing its strategy on localization, as well as acting as the lead for its COVID-19 task team. Dr. Iba is a global public health specialist and an emergency medicine doctor with over 20 years' experience working in humanitarian crises, health emergencies, and coordination in fragile, conflict, and low-income settings. Next, we have Jamila Bodo, who is the CEO of the Tamdeen Youth Foundation, which leads the localization movement in Yemen. Jamil has more than 22 years of experience in program and project management in humanitarian and development contexts, and is a member of the NEAR Network's Leadership Council and a member of the Operational Policy and Advocacy Group. Finally, we have Dr. Alex Mutanyangazi, who is a humanitarian public health specialist and a medical doctor from the Democratic Republic of Congo. Dr. Alex started his career working for local Congolese NGOs as a health advisor and as a medical doctor inside and outside of DRC. He joined Save the Children in 2014 to respond to the West Africa Ebola outbreak and has served as Save the Children's Ebola clinical team lead in Grand North Kivu from 2018 to 2020, and as its COVID-19 response team lead in Kinshasa in 2020. Thank you all very much again for joining us, and we look forward to hearing your thoughts and reflections throughout our discussion today. I will now hand it over to our moderator, Dagan Ali. Thank you, Dagan.
Thank you, Laura, and welcome to everyone. Good morning, good afternoon, good evening, depending on what part of the world you're joining us from. We're excited to have you here today. I just want to give you a little bit of background about Adeso's role in all of this. Adeso is an African organization that has been leading the localization efforts and leading in the recent past the decolonization of aid efforts, which includes the Pledge for Change and the NEAR network and all of that. We having worked with Save the Children as a member of the Pledge for Change, we also have been collaborating with them on various different areas of work, including now this READY project. And the pledge is focused on equitable partnership and advocacy for local first way of working and working in partnership with local actors as the default way of working instead of direct implementation by INGOs. As Adeso, we are trying to transition to becoming an independently funded organization. And so we've started various companies and social enterprises to reach this goal. And this includes a company called Kuja. And Kuja provides solutions to enable more direct funding and decision-making power in the hands of local organizations. And one of the services that Kuja offers is advisory services. So Kuja has been supporting the READY team to advise in the development and the review of the findings from the research. As the paper, you'll hear later from the authors of the paper, on the authors of the research, but the paper notes that local actors have always played a critical role in preparing for and responding to disease outbreaks. That's a fact that we all know about. And the COVID-19 pandemic served as the clearest example, confirmation of this reality. First responders were local, community-based structures of support and led by local experts and ordinary citizens through mutual aid efforts. This happened not only in the South, but also in the North. And this was the forefront of the response. The conventional aid system has often failed to recognize and appreciate the capacities and dedication of local actors. These capacities and skills can and should be strengthened, but this should be done with respect, solidarity, and in a way that is demand-driven, being responsive to what local health systems are asking for. Capacity strengthening should be seen as a two-way street. Local health practitioners can teach their Northern Western colleagues many valuable things too, because they operate in resource-restricted environments and function with severe constraints that many of the global North actors probably could never imagine. We don't have to look further than the current news right now, where we see the heroic efforts performed daily by surgeons and other health professionals in Gaza, who are operating on and treating patients with dwindling medical supplies under constant bombardment. And we also know about some of the great examples of locally led response in the outbreak of Ebola in Liberia and Sierra Leone. That was far different than the international aid response. So this discussion is also timely with the Shift to Power movement and in the lead up to the Bogota conference. And there's a growing and increasing demands for humanitarian development and philanthropic resources to be distributed more equitably across the aid ecosystem. This includes calls for more significant investment into health system strengthening from national to subnational and community levels. We must continue to have these conversations and ensure that attention on shifting power to local actors remains a priority for funders and the aid system overall. We also should know that the United Nations, WHO, and the Global Health Cluster need to increase space and opportunities for local leadership in outbreak response and fund this. Bilateral donors from the Grand Bargain, the SDGs, and other global commitments have not yet delivered the change that was promised in donor capitals that is expected on the ground. We know that the grand bargain commitment of 25% has not been anywhere. The donors have not reached anywhere close to that amount. We're talking about somewhere between 1.2 to 3.3% of global funding going directly to local organizations. And this prevents local actors from occupying leadership positions and perpetuates reliance on international actors. INGOs focused on health programming need to partner equitably and articulate your exit strategy from contexts where national and local health infrastructure requires resources and not band-aid solutions. National and subnational governments should be in the lead of major outbreaks. So first, to frame our discussion and to hear the perspectives of local actors that were identified in this paper, we will now have a brief presentation of the paper and key findings from Dr. Juliet Bedford and Dr. Helen Smith. So over to you both. Thank you.
Thanks very much, Degan. Good afternoon, good morning, colleagues. It's a pleasure to be with you today and to have the opportunity to introduce to you the paper that we've been working collaboratively with Ready over the course of the last number of months. I won't go into the background of this. I think, Degan, you have done an excellent job of laying out the context and the current situation. So before I hand over to my colleague, Helen, who will take you through the findings for today, what I just really want to emphasize is that this paper in itself set out to understand the current situation of localization, the current state of localization, the value of locally led action and the barriers to achieving it effectively. And it did this by trying to present the perspective of local and national NGOs and other actors. So this paper is a result of a number of collaborations and consultations with local and national organizations in the Democratic Republic of Congo, Syria, Yemen, and South Sudan, plus some consultations with key humanitarian actors and outbreak actors, and a detailed review of the literature. But it's important to remember that the paper really focuses on the perspectives, the needs, and the priorities as articulated by local actors themselves. And what we tried to do was synthesize the information and the perspectives they were offering to provide recommendations for locally led action during infectious disease outbreaks in humanitarian settings. If we can go to the next slide, please, Fasika. So just in the course of the next 8 minutes or so, Helen is going to walk you through the key findings, which we present here as 4 key actions. And it's these 4 actions that really structure the paper. They provided a foundation for dialogue and for future cooperation between local, national, and global actors, with the aim of driving concrete action and trying to break through the inertia that currently surrounds localization. Helen, I'll pass to you.
Thank you, Juliet, and also a pleasure to be here. So my job is to walk you through these findings as briefly and quickly as I can. Fasika, next slide, please. And what I will do is go through each of the key actions, but just to reiterate, this is a highly summarized version of the findings and the actions, and please do read the full report and a 2-pager for the detail. So the first finding relates to commit to localization as a process that has locally led action at the center of disease outbreak and response. Now, during the consultation, local and national actors rather championed the term locally led action and signified this as a process, a shift in mindset and structures towards locally driven outbreak readiness and response. So the actors that we consulted avoided the term localization and preferred locally led action. They also said that localization shouldn't be viewed as an endpoint, but rather as a means to less centralized funding mechanisms, more inclusivity, greater power and capacity to lead and maximizing existing resources and systems. So these were regarded as essential by the local and national actors that we consulted. And if we go to the next slide, please, Fasika, on the basis of this first finding around localization as a process, what actually needs to happen? And these bullet points, again, are summarized from the priorities that were identified by the actors that we consulted. So what needs to happen? Global actors need to define their approach to localization overall, but also specifically in relation to outbreak readiness and response. There's a need to acknowledge that internationalizing localizations doesn't mean localization. And likewise, expansionist business models that retain decision-making in high-income settings also need to be challenged. I'm going to pause so you can read the quote at the bottom, which aligns with this key finding. Okay, I think if we can move on, Fasika, in the interest of time, thank you. So our second key action from the consultation, and based on the findings from our consultations with local and national actors, redesign humanitarian architecture and emergency coordination mechanisms to prioritize locally led action in disease outbreaks. So those that we consulted voiced their frustration at the absence of decision-making authority. They have restricted access to flexible and long-term funding and limited influence and agency within the current humanitarian and outbreak coordination mechanisms. So there was a sense of frustration there from those that we spoke to. There were indications of greater involvement of local actors in coordination mechanisms and in decision-making processes, but those appeared as quite isolated instances within the complex humanitarian system and the coordination mechanism. And the national and local actors we consulted also said that the ultimate objective really should be a complete transformation of the system for it to become truly locally led. So in relation to this action, if we go to the next slide, what needs to happen, humanitarian and outbreak coordination structures and decision-making must become more accessible and inclusive. Funding models for both humanitarian and outbreak response need to be reformed to provide local actors with what they need in terms of funding, flexible, long-term direct funding options. And again, I'm going to pause so you can read the quote at the bottom, taken from one of our subnational actors. Okay, the third key action then is recognise and support effective outbreak readiness and response that is initiated by local actors. And I think Degan has already emphasised this point. The actors we consulted recognised that response starts locally. It's driven by local actors, but their actions are often unrecognised or undervalued by global actors. It was seen as critical to develop and support local solutions to outbreaks and equitable partnerships. There is some evidence from our consultation that these are emerging and leveraging local skills and knowledge, but the pace of change and the change in attitudes and power dynamics and trust needs to be accelerated. So in relation to recognising and supporting readiness and response that's initiated locally, what really needs to happen? Global actors need to acknowledge, respect and give greater visibility to the work of local actors in outbreak readiness and response. And commitments needed from global actors for partnership models that are equitable, collaborative and based on shared decision-making and trust. And again, there's a quote at the bottom. Fourth and final finding, trust local organisations to define their own technical organisational needs and capacities, and leverage skills and knowledge and sharing between actors in different geographical contexts. And so what do we mean by that? In the consultation, it again revealed that local capacity is frequently underestimated, underutilized in disease outbreak readiness and response, and capacity strengthening initiatives by global actors are too often based on perceived needs rather than actual needs. So there's lots of technical skills transfer, but very little leadership or organizational capacity strengthening. And there was some acknowledgement by global actors that there are advantages to cross-context skills and knowledge sharing, but this was not the norm at all. So what needs to happen? If this action is to be implemented, global actors need to be guided by local actors on where, when, and how they can effectively contribute in outbreak readiness and response. There needs to be investment in capacity strengthening for readiness and response that aligns with the needs of local and national actors. And it should include not just skills transfer, but organizational and leadership capacity strengthening as well. And I'll leave you to reflect on the quotes at the bottom of the screen. And that concludes your very quick summary of the key findings of the report. Back to Juliet.
Thanks, Helen. So the 4 key actions that we presented here really provided an opportunity for donors, for UN agencies, for INGOs to reconsider and reorientate the ways that they work in terms of their partnership models, the funding structures, and really the need to deliver on localization commitments. As Helen said, this is a very rapid summary of actually very rich details that are contained in the report. So we would really encourage you to please download. I know Laura has just put the link again in the chat, so please do access that. But I think all of us on the call today, can understand that there needs to be renewed commitment to make concrete advances to realize what needs to happen and to do this quickly, efficiently, and effectively. This is a collective responsibility. So my question to all of you on the call today is, what can you do within your own work, within your organizations, that can help within the spirit of solidarity and help really collectively advance us towards the changes that need to happen within localization over the coming months and coming years? And we'll just finish with a last quote, if we can, for Sika, to the next slide, which really summed up a lot of what our local collaborators and colleagues were telling us during the consultations for this paper. My thanks from the Anthologica team, and I'll pass back to Degan.
Thank you, Juliet and Helen. That challenge you posed at the end was really, I think, a really good question, because I think many people sometimes think that the answer lies in this massive ecosystem when people don't realize the power of the individual. I know that oftentimes our experience as a local organization with INGOs has been that it was personality based. It was having the right people in the right institutions who made a huge difference in the relationship, in the partnership, and the quality of that partnership. So I think that's a really good question to ask ourselves. So thank you for that. So now we'll just go to the panel. I'll start off with Dr. Iba, Dr. Pasha. So Doctor, I would like to ask you, what are the opportunities and constraints to making humanitarian and response and outbreak coordination mechanisms more accessible and inclusive? And what are the key lessons learned from recent action and the COVID-19 pandemic that should be adopted to better promote, support, and recognize locally led action during outbreaks?
Great.
That's a lot. That's a lot.
Yeah,
Sorry.
thank you. Thank you for that. I mean, it's a really important question, and we really welcome this report. bringing together the voices of local actors. I take note of the new phrase locally led action, and I think it's a very good phrase, and it'll help us drive the thinking on what we are meant to do as individuals, as partners, as actors, and collaboratively together. Opportunities or lessons learned. I mean, for your awareness, I'm not sure if people know, but the Global Health Cluster with the task team and 30 members, we conducted many studies over the period of during the COVID-19 pandemic, and we're really trying to delve in. Number one, looking at the issue of emergency coordination for an outbreak and its relationship to humanitarian emergencies and the coordination there. Sometimes it meets together very well and it works very well. Sometimes they're actually very, very different. So we know inherently there are some challenges, but also good practice around where those two coordination mechanisms can come together. But I just want to highlight some really good and interesting findings that we found from this is that actually at subnational level, it's not a surprise. It's not a surprise. Local actors are already engaging with Ministry of Health. They're already engaging. We know they work with the populations. We know they're working with populations affected by crisis. They know their needs and have that intimate relationship with them, are able to have access, are trusted, and have that capacity. But they're actually also already working with Ministry of Health and even for coordination. So with regards to implementation of activities, there is that dialogue and coordination ongoing with Ministry and Health. What the issues that we are finding is subnational coordination mechanisms themselves are not invested in. And so that is something that was a key takeaway, is that we need to move away from national planning, really get to as local planning as possible. You may have, especially in the countries that we work in, and it's not a surprise, that capacity for Ministry of Health or actors in general is far more challenging at local level. There's a reason why we are leveraging humanitarian actors or local partners. We need that extra reach, but that's not actually being recognized at the central level. So the work that's ongoing between Ministries of Health and locally led local actors with regards to whatever planning or activities that needs to be done isn't being fed up. And so the idea of local led planning, that's the first step, making sure everyone's included. We're already seeing that's happening, but ensuring that is being fed into those national processes is really, really critical. And we are actually seeing that locally led local partners are actually doing coordination functions for Ministry of Health or for whatever platform it is. So this needs to be invested in both financially, but also with support for partners. They're already doing this, so this needs to be further fortified in a systematic manner and not ad hoc. The other thing is bringing it back to populations affected by crisis and what they really need. We know partners, local partners, or organizations in general often do needs assessment, perception surveys, understanding what populations affected by crisis really prioritize what they want. And so we see a lot of assessments going on, and this may be fed back. And what we've seen from our studies is that this is often fed back to the local level. It may influence how activities are delivered, but actually what's really missing is the co-creation of activities of response with the population, so that whatever challenges and needs they are facing is being addressed, and programs are being implemented with them, using their ideas on how they want that response to occur. And the other biggest hurdle or challenge is the multi-sectoral aspect of it. It's not just about health. For populations affected by crisis, it's not just a health issue. We see this time and time again in outbreaks. It's sometimes about water, it can be food, it can be access to jobs, but it's the whole multi-sectoral impact that any crisis can bring along really needs to be addressed. So it's about taking it a step further beyond just understanding health needs or barriers, but really bringing in the populations to jointly co-create programs that are meaningful for them. So I'm just going to leave it there for the minute, keeping within the time limit, but there are lots of other points I could come back to as needed. Over.
Thank you, Doctor. You know, the last point you made about multi-sectoral and the siloing of things, it's one of the things I've always been frustrated about with the aid system, how humanitarian is siloed from development, water is siloed from health or education. And it's one of the perpetual problems. That's not how human beings function. It's not just communities in the global south, but human beings are multi-sectoral by nature. That's how we are. And it's just the Western design of this architecture is not fit for purpose. So it's one of the things I feel like it's not even debated anymore. It's assumed that it's fine. And we keep talking about locally led action in terms of power and resources being invested in local actors, but not actually how the system is designed to really be harmful to communities. So I'm really happy that you mentioned that. That's really a critical point. Thank you. Let me ask Dr. Alex about, based on your experience, extensive experience, especially in the DRC, what do you think are the critical existing capacities of local actors, including communities themselves, that need to be recognized and promoted? And in what ways can the broader humanitarian community support partnership models that are equitable, collaborative, and based on shared decision-making?
Okay, thank you for that question. So before giving the answer, let me first remind about the situation of DRC. As you know, DRC is known as one of the countries with largest and most humanitarian crisis in Africa, and I can say also in the world. And you know that in DRC, we are exposed to many outbreaks. As you can know, we are now in our 15 Ebola outbreaks. We have the outbreaks of COVID-19 last time. We have many outbreaks of measles. We have cholera. We have also some outbreaks of meningitis. So, for example, for the time I come working here with Save the Children from 2018 to 2023, I can tell you that I have already responded to the big Ebola outbreaks in North Kivu and Ituri, another one 2 times in that area. I have also responded already to outbreaks of COVID-19, outbreaks also of measles and cholera and other outbreaks. So when they respond, the local organization, when they respond to those outbreaks, they develop now some health system resilience, so that you can see that we have some capacity, human resource expertise here in DRC at a different level. So at minister's level, you're going to see, for example, we have protocols, we have defined politics, we have now SOP that we can just, if we have another crisis, it will be easy for us to respond immediately. But also at the local level, we have already trained, we have now many actors with a lot of capacities because they got a lot of training, so that you can say that they have this expertise for the future outbreaks. We can say also we have some resources, some infrastructures that we can just have locally. For example, I remember before this Ebola or COVID-19 outbreaks, the country could not have, for example, some good capacity of testing. But with this Ebola, now we increase our capacity of testing. So we have now a lot of lab for tests. I remember before we had just one big laboratory in Kinshasa, but for now we can just have other laboratory for testing in the other area of the country. We have also this, as we can say, the capacity is this community dynamics, because this community dynamic that involve also all the communities driving forces. There I can say the community health workers who are really trained. I can say all the communities leaders. I can say all the religious, traditional leaders who are now trained for the community-based surveillance. They are also have now the capacity for their outreach activities. So for now, I think that if there is another outbreak that can come, we have already we have the capacity, for example, to detect them and to respond immediately. And also the other capacity is now the local organization today. I think that they have this multi-sector emergency preparedness plan. I think that also is now a good thing that locally, at the local level, people are now well organized around the health system, that we have the MOH, and around the MOH we have all these leaders that can sit and plan for emergency preparedness plan. They have also some contingency plan, so that can allow them that if we have another shock on the future, they can just be able to respond on it immediately. For the questions about what the community, humanitarian community can give us support to the partnership model, what I can say that we have just to develop the partnership that can promote the process of transferring power to the local organization. And there, we can just do it if we just respect the principles of partnership. There, I want to talk about the equality, the transparency, the partnerships on the result-based approach, and the accountability and complementarity. So for now, what we want now, we advise, is to try to develop some initiatives that take into account the local needs of community. For example, for now, with Save the Children, with our partnership department, we are trying now to see how we can start to work with the local organization from the need assessment. So we can just do the needs assessment together. So we make the design of, for example, the initiative together. So we can sit together also, we define the role of each stakeholder, and to see how we can just together continue. For example, for now, when we are talking about the consortium, before the prime was just for the international organization, but for now the discussion is why we can't now give the prime to the local organization, and also the international organization can continue to work under the leadership of the local organization. There is also a question about the capacity building. When I talk about capacity building, I talk also about the questions of governance. So I think that we have to provide for now more effective capacity building support, and also to increase our opportunities for mutual capacity building. So it must be the capacity building that can go to the two directions. So from the local organization for the international organization, and also for international organization to a local organization. The big problem also is about to think about the visibility, the leadership, and the representation of the local organization. Because for the past years, the local organization could not have a good visibility of what they were doing. So I think that for now, it's better also to expose them. For example, for the report to the donors, for discussion with the donors, it's better now to expose also the local organization, so that they can have also the same chance to have some fund to finance their activities. And also, I cannot also
Thank
finish
you, Alex.
without...
Dr. Alex,
Okay.
sorry to cut you, but we're running out of time, and I want to just end with that last point about visibility, because this is one of the commitments in the Pledge for Change, authentic storytelling. And it's not only about addressing issues of poverty porn, but it's also about giving visibility publicly to partners. Whenever you see an interview of a CEO of an INGO on CNN, they never really talk about their partners in the response in DRC or in Liberia. We need to change that and have the partners be featured in articles and maybe even ask CNN to talk to the partner rather than the CEO, you know? So I completely agree with you. This is an important part of, I think, genuinely having locally led action and supporting and investing in the partners. Thank you so much, Alex. Let me move to Jamil. Jamil, I want to know for your thoughts on your organization in responding to outbreaks in Yemen, and what skills and capacities do local actors, including communities themselves, bring to outbreak response that's been overlooked in the conversation so far, and what should the donors and the international community do differently to support locally led action?
Thank you very much again for this, and realizing the importance of locally led response in the outbreaks. Our organization, Tamdeen Youth Foundation, is play a great role in this aspect. We've been involved in responding to a lot of outbreaks here in Yemen. Yemen faced a lot of outbreaks: cholera, dengue fever, malaria, and also COVID-19. We've been involved in the response, and we gain a lot of experience and in responding to these outbreaks. The local actors have a variety of skills and capacities in responding to outbreaks that being overlooked from the global community and the donor community. For example, part of these skills are the local knowledge. Local organizations and entities have a rich knowledge of the local environment and the health risk that threatening it. This knowledge help in early detection of the outbreaks and in taking the necessary preventive measures. This knowledge, for example, local communities may be aware of signs and the symptoms of infection disease that may not be known to external actors. Also, trust with the population. Local actors gain a level of trust with the local population that cannot be achieved by the international organization or external actors. This trust can help build population commitment to preventive measures and the rapid response to the outbreak. For example, residents are more likely to comply with the health recommendation issued by local actors they trust. Also, the flexibility and adaptability. The local communities are flexible and able to adapt to changing circumstances that according to the resource available to them. These skills can help respond to the outbreak that occur in a complex and difficult environment. For example, local communities may be able to adapt to outbreak response procedures or make it contextualize these procedures. Donors and international community can do a range of action differently to better support local action in outbreak response. Among these actions are the following. For example, recognize the important role of the local actors. Donors and the international community can recognize the important role of local actors in responding to the outbreaks by including them in the planning and the response process. Not just the response, or not like treating them as implementing the response, but during the planning for the response. Also, strengthening the cooperation between local and international actors. The cooperation between local and international actors can help in exchange experience and skills and coordinating the effort. Providing the necessary funding and the flexible funding for the local actor. This necessary funding helps strengthen the capabilities and also making or accelerating the response. Also, focusing on the capacity building of the local actors. But by doing that, this could include providing training, technical support to local actors, as well as funding for the capacity building project. So also supporting the establishment of a national network of local actors in the field of outbreak response. This network can help enhancing cooperation between local actors and exchange experience and skills. Also, not only is just in the involvement of the local actors, also supporting the involvement of the local communities in the outbreak planning and response process, because they know the context, they have the ability and the capability to implement the preventive measure. Also, they have the trust of the community. Thank you very much.
Thank you so much, Jamil. That was really helpful to hear about that, especially all the capacity building needs and the national networks. I think that's one of the investments that doesn't happen enough is national civil society networks and coordination mechanisms. Thank you for that. Because we don't have a lot of time, I think we might only get to 2 questions. So I'm going to first ask maybe the question around co-creation. The question was, we totally support the idea of co-creation. We have some experience with that. And in this experience, it took a long time, also because the communities are diverse and you want to be sure that different voices are represented. So how does this work in an emergency response? Since you talked about that, Dr. Pasha, maybe you can respond to that question.
Yeah, hi, thank you. I was trying to type an answer at the same time, but I'm glad this is being brought up because I think it's really, really important, where we actually need to do better around this. We have frameworks, you know, like the ISC framework, you know, accountability to affected populations, where we are meant to be doing this. It's very clear that participation and engagement of the community in defining the response should be done. So we have these policies that already articulate this, and actually also more recently in a WHO framework on health emergency preparedness and response around co-creation. That we do need to integrate these voices so that we can respond to it. How much is it being done right now? From what we saw, not much. So I'm very grateful, and you know, we take leadership. Happy that there is partners who are leading on this already. There are some activities around safe, dignified burials. We know IFRC do a lot around community engagement. It's all there, but we need to do stronger within this. And also, you know, are we measuring this as a performance, a measure of success when we are engaging communities in developing this? Is this what we're reflecting in our donor proposals? Is this what are we articulating it as a measure of success when programs are developed as such? We need to shift the way we operate, not just as an individual agency, but as a cluster. It's for us to ask our partners, have you involved them in developing your program? And should this be part of the humanitarian response or not? So we all have a role to play both individually and collectively, I think.
Thank you for that. That's really helpful. The second question is really political. So it is about donor governments. And it's about, it says there's a huge amount of discussion of global partners needing to change how we work. We get to see what is being asked of INGOs. But taking an example of the UK government, FCDO, they are clear that UK aid money is to enhance the interest of the UK government. Widespread localization is the opposite of the stated aim of government funds. What is the conversation aimed at the global donors and political entities? How do we change the needle in improving the quality and the ability of these funds? I'm not sure who wants to respond to that. Maybe Laura, as a partner of FCDO and USAID and all of that, or Juliet.
Thanks, Dagan. I don't think it's really for me to respond to that particular question, although I am based in the UK and I'm and we do work closely with that FCDO. But I'd be interested in hearing either from Laura or other SAVE colleagues who might be on the call who would have a better response around that funding environment from the British government.
Laura, are you there? Or Rachel? I don't know if you're with you. Say.
Hi. I can come in on the hot seat. Hello, everyone. I'm Rachel Cummings. I'm the head of humanitarian health at Save the Children. I mean, it's an extraordinarily difficult question, isn't it? Because we have identified, not only with the development of this paper, but through our work with local partners in terms of our Save the Children country offices, you know, how the added value, I guess, and the role that international organisations can play in sort of complementing, collaborating with local partners. But we are one part of a very complex ecosystem, Save the Children and international agencies, and the funding models and how funding models are developed. And I'm sure, Dagan, you could speak to this for many, many, many hours, but are not designed for money to flow to local partners in a straightforward and simple way. We have made organisational commitments and sector-wide commitments to increase the proportion of funding that goes to local partners, but that isn't a straightforward shift. So we have, you know, bureaucratic, hierarchical challenges, but we also have sort of systemic challenges within the sector. I guess the question is then, what role can we all play in that shifting that dial? As I think it was Andrew that made the question, and I think it's multi-pronged. So we all have a different relationship with donors, whether that's at a base level or a global level, and we all have a role to play in advocacy. And I think one thing that could potentially come from that is sort of combined or collaborative advocacy, acknowledging the voices in the room and in the conversation, but also acknowledging the space at the table that some of us have, and to be more potentially strategic or propositional with that power and influence that we potentially have. So not a straightforward answer, but it's a very complex ecosystem that we're all operating within. I hope that touches on some of it for people.
Thank you, Rachel, for agreeing to be on the hot seat. So I would just like to add also, Pledge 3 commitments is about influencing the wider ecosystem. So there is, all the signatories have made a commitment to influence their back donors, whether it's FCDO or USAID, as well as their peer organizations. More effort needs to happen in that end. I think currently a lot of the work of the INGOs has been internal focused. How are they better partners with locals, how they move more money, how they share overheads, but there hasn't, I think, as of yet, been enough collective work on how to influence the donor. So I think that's one thing that we need to put a lot more effort in the future. I think we might have time for one more question. And the question is, of course, sectors need to work together to deliver a holistic response, but to be locally led, There's also a need to work with local government structures which are broken down similarly, generally with a Ministry of Health, Education, Sanitation, etc. Dagan described this as a Western structure. So I'm interested to know if there are alternative structures in place in any of these contexts where participants work, which might help inspire how to break down these silos. Maybe I'll ask Alex, Dr. Alex, if you can take, have you seen in your extensive experience alternative structures that could work in the DRC that are maybe led by the community, the private sector? And what is your response to the siloing of these existing structures?
Okay, thank you for that. I don't have a big experience in DRC, but what is going on for now, we try to bring everyone on board, and we try for now to, for example, for the outbreaks response, to see how we can just give more power to the government, and the government try to bring all the sectors in place to have a response that is going to include everyone. But for my experience, I don't have more experience to share. Thank you.
Thank you, Alex. Pasha, do you want to respond to that, or Jamil? Any experiences you have to share on that before we close?
Not really. I think what we saw from our studies with regards to COVID-19 is that and not the first time, but it was definitely a time when government established national task forces that were multi-sectoral. They were either like presidential task force, bringing in different ministries. I think we saw that in COVID-19. Do we see that in other large-scale outbreaks? So where it's cross-ministry, and so where we are able to liaise with across ministries better for a multi-sectoral response. Do we see that with others? Less so. But I think COVID-19 definitely. I think from our thing, it was 80% had presidential, multi-government, multi-ministerial task forces, and that was related down to the local level as well, so the district commissioner, etc. And so that's my
Thank you, Dr. Pasha. Yeah, thank you. I think on that note, if it's okay with all of you, I'll just close because we're just running out of time. First of all, I want to thank all of you for joining us for this session, and Ready Project and the team, and for conducting this really good, solid research on locally led action. So just in summary, I think some of the highlights, takeaways from this conversation has been a need for a complete transformation of the system for it to be really, truly locally led, programming to human beings and changing the way that the system is actually designed. Just in response to that last question about the silos and this architecture as it's been designed, my feedback on that and local governments, I think that the system actually is designed in a humanitarian context to not support local governments, and it's not incentivized to invest in local governments, but rather to invest in international aid actors. And I have seen situations where the governments are in competition for resources with aid actors. So that has to change completely. And the siloing can never stop if the donors don't stop their siloing of the money. If the purse strings are siloed with humanitarian development, water, health, education, then the siloing will never stop. And then we need to trust local actors and communities to make their own decisions. That includes funding them appropriately and enabling their flexibility and adaptation of programs. We also need to change what accountability means and looks like, and figure out how to ensure communities are holding us accountable to co-creation and responding to their needs. So on that note, we're right on time. So I want to thank you all for attending, and I would like to close out the session. Thank you all. And please check out the full report. The link has been shared with everybody again.
Thank you, everyone. Thank you, Dagan. Thank you to all the panelists and to Anthologica for your support and collaboration throughout this process. Have a great day, everyone.
Thank you. Bye.
Thank you very much, and thank you all.